disorder. So it is one of the best methods for prevention of cardiovascular disease, and WHO describes this mode of intervention as the best buy mechanism. It gets the best possible value for the money. But there are a few ambiguities which I'm going to discuss in my talk. Yeah, so this is classically known as a Johari window. Now, this we use it for knowing ourselves and what the other knows it. I've slightly modified it, and I've divided it into four different subsections. The header part is known as the what we know and what we practice. And the other part is the less known thing. Most of the cardiologists and most of the physicians are less aware of it, even though there are evidences, they are less aware of it. On the left-hand side, we have the strong clinical evidences. But these evidences have arisen from large systemic reviews and meta-analysis, a large prospective cohort which have followed the patient for 10, 20, 15 years, and they have become the base of our clinical judgment and clinical practice. The second group is those which have weak evidences. So if you see this triangle, if you see this square, you see four different sectors. The first sector is what is known and practiced. So we know it and we have strong evidence for it. So we practice it. The other part on the right-hand side is the what is less known by us, but there are strong evidences for it. This becomes our blind spot. I mean, even though we know it, the evidence is there, but somehow we don't follow it because of either it is less talked about in conferences or less discussed. So that becomes our blind spot. The third area is the area of ambiguity. We are so sure about it, but we really don't have evidences, or the evidence which is presently present, it actually is weak. That is the area of ambiguity. And the last sector is the unknown sector. The proverb, what the mind doesn't know, the eye cannot see, is truly applied in this sector. Something which we do not know and which we don't have evidence for. We are not searching for it. That becomes the true unknown part. So I'll try to fill in the gaps where as we go along. So before we proceed, I would like to divide and get clear on our terminologies. First, something is known as sedentary behavior. Then something is called being physically active, and something is being called physically inactive. So what is sedentary behavior first? So any waking activity, if you're awake and if you're carrying an energy expenditure of less than 1.5 minutes, like sitting, reclining on a chair, lying posture, we are sitting and listening to a conference, what we are doing is doing a sedentary behavior. Our energy expenditure is less than 1.5 minutes per kg per minute. So that is, we are having a sedentary behavior. So what is being physically active? The 4 here is the reference, so please don't get confused here. So being physically active means any body movement which generates the contraction of large skeletal muscles, which raises the energy expenditure above the basal metabolic rate, and it is characterized by mobility, frequency, intensity, duration, and context of practice. Now, the American Heart Society and various heart societies refers to having a physical active behavior when you are doing more than 150 minutes of moderate activity a week or more than 75 minutes of vigorous activity in a week. That becomes you are physically active. So what is being physically inactive? Physically active means if we do not achieve this goal of 150 minutes per week of a moderate activity or 75 minutes of vigorous activity, that means we are being physically inactive. So these three terms need to be understood as we proceed in our talk. So what are the side effects of sedentary behavior? Now the defects start at the very mitochondrial level, and this becomes a very important part. The defect starts from DNA deletion, and mutation. There's abnormality in the electron transport chain, and there is decreased mitochondrial content and respiration. These translate into upscaling of various oxidative stress markers, and they cause depressed function of sarcoplasmic reticulum in the cardiac muscle, and ultimately hardening of the cardiac conduit, which may lead to endothelial dysfunction, which may cause heart failure, and may predispose to coronary artery disease. So the point to understand here is that defect starts at the very, very mitochondrial level, and it is at the genetic level the effect starts taking place. So the outcome has various outcomes. It not only leads to cardiovascular diseases, it also leads to cancer and many diseases which are related to the generalized body. So what is the hazards of having a sedentary behavior? Now, there's a study by Elkund et al. He pooled data from 1 million patients, that is 1 lakh patients, and they were followed for a period of 13 years. And he found people who were less physically active had around 70 to 80% higher risk of development of cardiovascular disease and death. This is economically, this is statistically significant, and this was very important. And as the activity increased, their likelihood of developing cardiovascular disease and all-cause mortality gradually reduced. And this is a large cohort study of 1 million patients. So where is the ambiguity here? I mean, we are very clear sedentary behavior is bad. So why are we so ambiguous about? First, there is no quantitative recommendation. That means how much of sedentary behavior is bad? Is it 30 minutes? Is it 40 minutes? Is it 6 hours, 5 hours, 8 hours? None of the guidelines, present guidelines, talk about the amount of production of quality of sedentary behavior which we need to have. Most of the guidelines just write this statement: reduction in the bouts of sedentary behavior. Bouts is a very qualitative term, and interrupt is a bout of light and intensity activity. And that is what they conclude. So in fact, if we are sitting in our conference and often go out for a cup of tea, that may be very bad for the presenter who's talking, but may be very good for you because you are interrupting this bout of long sedentary behavior. So a person, just imagine a scenario where a person who is physically active for the first 2 hours in the morning and sits for 8 hours in an office. Does the behavior for 2 hours is offset by the 8 hours of sedentary behavior? We really don't know. So we need much more better studies, much more better meta-analysis to identify this critical threshold. And identifying this critical threshold is very important. I'll clarify it in my next slide. So the second part is physical inactivity. That means we are not adopting a sedentary behavior, but we are physically inactive. We are not able to achieve the expected guidelines. So what happens with that? Now, physical inactivity has been linked with the greatest risk for development of cardiovascular disease and death. By eliminating physical inactivity, it is expected that we are going to increase our lifespan by 0.68 years. There are longitudinal studies which have followed patients for more than 31 years and have shown that people those who are physically inactive have around 17 to 15% more likelihood of development of impaired glucose tolerance and ultimately diabetes. The modulatory mechanism for physical inactivity causing cardiovascular ill health is a bit complex, but it all boils down to oxidative stress. There was an experiment that was done by Boyle et al. And he did a very beautiful experiment in which he asked very physically active males who were walking 10,000 steps per day. And he measured their popliteal artery flow. He asked them to reduce their activity of 10,000 steps per day to 5,000 steps per day. Within 5 days, he noticed there was a decreased reduction in the flow of the popliteal artery. So here the stress limit for sedentary behavior becomes very important because then we have to know how much of sedentary behavior timing we need. So now again, moving to, as we move further in our talk, we always talk about moderate activity and vigorous activity. Now, on a quantitative scale, a moderate activity is defined as something of achievement of 5 to 7 meds, and a vigorous activity is something 7 to 9 meds. Now, remember the definition is also has a qualitative domain. So we need to understand because it differs from person to person. A moderate activity is defined as an activity which requires an effort on the part of the person where it causes acceleration of heart rate, and on a scale of subjective personal capacity, it's of scale of 5 to 6 on a scale of 10. Now remember, a person who is moderately obese or a big obese person, for him moderate activity would be different from a person who has less BMI and who has a different occupation. So for him, the moderate activity would be different. For a person who is nearly fit, the moderate activity would be different. What is vigorous activity? A vigorous activity is one in which a person has an increase in heart rate, but on a scale of 10, he feels it's on about of 7 to 8. And it includes activities like walking, brisk walking, climbing a hill, fast climbing, aerobic exercises, fast swimming, and competitive events. The current guideline says you need to have 150 minutes of moderate activity or 75 minutes of vigorous activity. Now, these cut points are very important, and also to understand moderate and vigorous activities are different for people, those who are of different weight category, of different physical capability, different race, different gender, and also different age category. So what are the benefits of physical activity? Now, again, the benefits start at the very mitochondrial level. It leads to an increased mitochondrial protein level. It leads to upregulation of various inhibitory antioxidative stress markers. They gradually increase the mRNA, decrease the mRNA expression, and ultimately leads to a lower expression of P53 gene, which is linked to aging, the P21 and the P16 gene, which is linked to aging. Now, these are senescence genes. The decreased representation of these markers actually decreases the aging and increases lifespan. So the benefits are dramatic. Now, so what are the physiological benefits of being physically active? Being physically active has a hallmark of plethora of physiological benefit. I've tried to summarize it here. It causes a reduction in blood pressure, reduced systemic inflammation, improves heart rate variability, increases lean muscle mass, it improves sleep, it improves psychological stress, it decreases blood viscosity and plasma viscosity. All this ultimately leads to reduction in hypertension, osteoporosis, depression, osteoarthritis, metabolic syndrome, dementia, Alzheimer's, diabetic mellitus, and various other cancers of breast and colon and other cancers. So being physically active is good. Maintaining a good physical activity is good for the cardiovascular stress, whether it is done in low volume or a high volume. And there are clear benefits which extend across age, gender, and race. But what is the problem here? According to the various studies, there are only 20% of people who actually meet the current cutoff guideline for being physically active. And this is because of a plethora of reasons that includes personal barriers, it includes lack of time, or there are large misconceptions about the volume of the work. If you're asking a 60-year-old man or a 70-year-old retired person to be active for 30 minutes in the morning, he may choose not to do it because he may say, yeah, 30 minutes is too big a time. I don't want to do it. He may get too tired. So there is no misconception about the volume of the work. Now, this was a study which was done among the elderly population, and they found if you are trying to do 150 minutes of a moderate physical activity, and you have 6 things, 30 minute slots, and the 30 minutes of each circle, small circle, even 30 minutes of slot, so you have around 180 minutes of physical activity. And then they had other group of elderly people whom they divided this same slot into less than 10 minutes. Actually, the mention is 10, that the volume of work was less than 10 minutes per day. And they found the all-cause reduction in mortality did not differ significantly. It did in the first group, there was 41% reduction. In the second group, in the 40%. That means among the elderly population, even small bouts of exercise carried out multiple times in a day, if you meet the target of 150 minutes or a 75 minutes of vigorous activity, you actually end up having the same benefit if you are doing it in a larger duration of time. Remember, this study was only done among elderly. The benefits for its study to be done among people who are not of elderly, who are young and who are adolescent is still not shown. So this study, it showed a very similar reduction among people those who have large volume of work and people those who have less volume of work. Now, there are other studies which we showed the all-cause reduction among runners and non-runners. Obviously, the runners had better advantage. They had better reduction in all-cause mortality and all-cause cardiovascular health. But if you look at this data in a very different way, because runners are generally unfit by nature, but non-runners are generally unfit and runners are fit. So this comparison is not good because we are comparing apple and oranges. If you just see the runners and divide them into quantiles, let's say you divide each part into part of 5 and see the lowest category of runner and the highest category of runner. You see the chart here, the lowest category of runner and the highest category of runner. Forget the first comparison non-runners. You see the reduction in cardiovascular death and all-cause mortality is actually the same. That means we are running even at a speed of less than 5 to 6 miles per minute and a distance of less than 6 miles per week, and you are carrying the activity for around an expenditure of less than 5 or 6 minutes, you nearly achieve same benefit as the person who will be achieving a very higher quality of benefit. So running even in a smaller quantity, if you are achieving the target according to your need, you are going to achieve the benefits irrespective. And this benefit is not exponential. That means it doesn't mean you're going to exercise for a large around 2 hours of activity every day, and instead of doing it 10 minutes, and if you're able to achieve the target of 150 minutes, the benefits will be the same. That is what the study showed. The other two terminologies that I'm going to bring about is exercise training and sports. Now, being physically active is different. Doing an exercise training and carrying out a sport is different. Now, exercise training means a subcategory of physical activity that is planned, structured, repetitive, and favors physical fitness and maintenance or development. Sports is a part of physical activity which corresponds to institutionalized, organized practice arranged over a specific period of time. Now, exercise training is what we do in our gym, or we have a physical instructor who who asks us to do a repetitive structure, either isotonic in nature or isometric in nature. So exercise training, sports, and being physically active are three different components. So if you divide these components into individual things and put them through a funnel, ultimately it leads to a better cardiorespiratory fitness. Cardiorespiratory fitness means we are able to use large amount of oxygen, which is more than we're going to age, for our large skeletal muscles. The oxygen consumption by our body improves and ultimately leads to an improvement in cardiorespiratory fitness. Now, this cardiorespiratory fitness is actually the strongest predictor, not the volume of physical activity, not the exercise training alone, or it is the achievement of cardiorespiratory fitness is the strongest prognostic marker. The gold standard method for assessing the cardiorespiratory fitness is by the V2 max, which we do through a cardiopulmonary exercise by using a gas exchange analysis. We can also do it on a treadmill, and we have a 6-minute walk test, where 1 minute increase in cardiorespiratory fitness leads to a reduction 13 to 15% of all-cause mortality and cardiovascular death. The older study which shows the cutoff values for male and female, for fit male who do not have asymptomatic, who do not have cardiovascular disease, a male who is less than 40 years of age should be able to achieve 9 meds. A male who is of 50 years should be able to achieve 8 meds, and a male who is more than 60 years of age should be able to achieve 7 meds on routine physical activity. We can easily, this cutoff criteria is different for people, those who have cardiovascular disease, those who have heart failure. We can look up the guidelines and go through them. So it is important for all of us to measure the cardiorespiratory fitness of all our patients who are having heart failure, coronary artery disease, or those who have asymptomatic cardiovascular disease and are physically fine, because this ultimately predicts the all long-term all-cause mortality and cardiovascular death. So this is the guideline which talks about the V2 max in cardiovascular disease. People, those who have in the upper quantile, those who have more than 40, who have age 20 to 39, and who have oxygen consumption of more than 41 ml per kg per minute, have the best prognosis when compared to similar age people, those who have less than 28. These charts are given everywhere. You can look up on the internet. Okay, so what are the benefits of cardiorespiratory fitness? Studies by Blair et al., Lee et al., and Elkun et al. These are large cohort studies, prospective cohorts, and having more than 1,000 patients or even more than 1 million patients, 10,000 patients to 1 lakh patients. All these showed reduction in cardiovascular death and mortality among physically fit individuals who have good cardiorespiratory fitness, and ultimately concluded for a 1 minute increase in cardiovascular fitness leads to a reduction in 15 to 19% reduction all-cause mortality and cardiovascular death. Okay, now to understand the obesity paradox. Now, this is a very interesting thing. You have two individuals, one individual who is class 1, class 2 obese, and other individual who has a good BMI. So we noticed something through a very good epidemiological study, and this showed there is an improved prognosis of people those who have higher BMI, in particularly in case of coronary artery disease, heart failure, and atrial fibrillation. What does it mean? The people those who have class 1 and class 2 obesity have better prognosis than people those who have lower BMI. That means, is our measurement of adiposity is wrong? Are we not finding out if they may develop heart failure or this thing part? But if they develop the disease, you compare these two individuals, the obese person will have better outcome than compared to person who has less body mass. So this was the obesity paradox. This obesity paradox is solved again by understanding cardiorespiratory fitness. It is seen by a study by Mackley et al. It followed around 9,000 individuals for a period of 13 years, and we found individuals with who have poor cardiorespiratory fitness and poor BMI or have thin have the worst prognosis. People, those who have a better BMI and better CRS. That means if you are thin and if you have better cardiorespiratory fitness, you are bound to have better prognosis. An obese individual will always have a better cardiorespiratory. If he has a better cardiorespiratory fitness, he will have a better outcome. Even though he has a poor cardiorespiratory fitness, he will have better outcome compared to a person of low body mass who has poor CRS. And this has clinical implications. Why? Because if you are focusing on decreasing of weight and improving the cardiorespiratory fitness, first focus on improving the cardiorespiratory fitness. As you improve the cardiorespiratory fitness, it may lead to an increase in basal metabolic rate that will ultimately lead to a loss in BMI. So focusing just on reduction of weight and not improving cardiorespiratory fitness may have disastrous consequences. So how do we improve cardiorespiratory fitness? Now, any form of physical activity which you are capable of, either doing brisk walking, doing moderate activity, is bound to increase cardiorespiratory fitness. There's other techniques of doing high intensity exercise in short intervals of 10 minutes, doing short jogging of 6 minutes or 5 minutes, and then stopping, taking rest, and then again doing it after 30 minutes or so. That is known to show an increase in cardiorespiratory fitness. Most of the physical trainers give the guidelines in a similar way. They say first increase the frequency of exercise. That means if you're exercising 1 to 2 times in a day and it is not a physically active guideline, first try to become physically active. Try to exercise for around 10 to at least 8 to 9 minutes, 2 times in a day or 3 times in a day, for 6 to 7 times in a week. So you achieve the target of being physically active. Then increase the volume. That means from 10 minutes, you're able to do it for 10 less than 10 minutes, then try to make it 12 minutes, 14 minutes, and slowly increase the volume. And then as you go along, when you have built up your endurance, try to increase the intensity. Don't start with increased frequency, increased volume, and increased intensity at one go. If you start doing that first, last step at one go, you're going to bound up in a hospital earlier than you would have wanted. So this is the way you got to build up and follow it over a period of months and sustain it for a longer duration of time. And that will ultimately lead to an increased cardiorespiratory fitness and decrease in all-cause mortality. Now, does yoga improve cardiorespiratory fitness? There are many Indian studies which do show that there is an improvement in cardiorespiratory fitness through yoga. But the large meta-analyses which are present up till this amount of time do not show any benefits of cardiorespiratory fitness. They show yoga does increase balance, mobility, low body flexibility, but it did not have any effect on cardiorespiratory fitness. A subgroup analysis among elderly, they show the yoga does have particularly positive effect. So at this moment of time, we do not have enough evidence that yoga improves cardiorespiratory fitness or the breathing exercises. Even the American Association of Heart Diseases, when it classifies moderate activity, it includes active yoga as an example for improvement of cardiorespiratory fitness or improving as activity. But remember, the word here is active yoga, not breathing exercises, not other exercises. It improves active yoga. So that causes moderate activity, and that can be done because the evidence is there for people, those who are in the elderly group. A big part of our study could be understanding the effect of cardiorespiratory fitness by yoga, which can be studied by our colleagues. So what do we presently know? We presently know and we practice having a sedentary behavior and having a physically inactive lifestyle is bad. Being physically active, carrying out 150 minutes, at least 150 minutes of moderate activity, whether in a small volume or large volume or small frequency or large frequency. If you meet the target guideline, if you're doing it for 6 to 7 minutes, 4 times a day, and if you're carrying out for 7 times a week, you are meeting the target of moderate activity. That is good. So what is our blind spot? We do not assess cardiorespiratory fitness. Even in large tertiary care centers, we do not assess cardiorespiratory fitness. It is vital that all our patients who have stable anginas, who have stable heart failures, need to have their baseline levels being checked. We do their echocardiography, but we do not measure by them by 6-minute walk test. Earlier it was being done, but with advancement of new tools, we just check for the NT-proBNP level, we check all biological markers. That's just a simple assessment. We ask the person that, are you exercising? They says, I'm doing, but we don't verify it by doing a 6-minute walk test or a modified Bruce protocol. So you can easily assess whether he's having a good cardiorespiratory fitness or not. If he's not able to achieve the increased heart rate, poor effort tolerance at an earlier stage 1 or stage 2, that means he's not exercising. You can hire a physical trainer for him and ask him to increase the frequency of exercise and assess cardiorespiratory fitness, because that will predict the all long-time mortality and rehospitalization. There are certain areas of ambiguities. Ambiguities is the duration of sedentary behavior. We do not know what duration of sedentary behavior is actually detrimental. The effect of yoga on cardiovascular fitness is still not known. We have very poor evidence. Studies need to be done. The true unknowns, because there are drugs like ACE inhibitors and sildenafil have shown significant improvement in cardiorespiratory fitness among patients who have heart failure with reduced ejection fraction. These drugs have shown to improve cardiorespiratory fitness and have improved prognosis and decreased hospitalization. These drugs have given way for whether we can develop new wonder drugs through which we can improve the cardiorespiratory fitness in people who are seriously unable to have good physical activity, who are morbidly obese, who just can't get up from the bed. Do we have a drug for them? And the other option is gene therapy, because you saw the detrimental effects start at the very genetic level. So what if we are able to completely get over the gene? Just correct the gene. Some people may have defective gene from starting altogether and may predispose them to have a poor cardiorespiratory fitness, a low basal metabolic rate, and ultimately leads to a cardiovascular disease, irrespective of how much they exercise. So gene therapy in the future could pave a way for just clearing and just coming out of improving cardiorespiratory fitness. These are true unknowns. A large part of study has to be done, and studies will cause a significant change in the paradigm of how we think about physical activity and cardiorespiratory fitness. So what are the take-home messages? First, avoid sedentary behavior. Be physically active. Don't be sitting around in front of television for more than 1 hour or 2. Take breaks and move out. Go see, play with your children. Be active. Do activity which you can do, but try to achieve the guideline of 150 minutes of moderate physical activity. Try to prescribe activity according to age group and the condition of a patient. Don't ask a very morbidly obese patient to join the gym. Ask him to start slow, increase frequency, then increase frequency and increase volume, and then increase frequency, volume, intensity. Make it a gradual process. Make it a part of a lifestyle than once in a off. Always assess cardiorespiratory fitness for all your patients from the start. And as we follow with our LV function, you have to measure cardiorespiratory fitness, and this becomes a very important part for our current guidelines and future guidelines. And obviously maintain healthy lifestyle, avoid tobacco and alcohol. This becomes our take-home message. In the end, I like to finish this talk with a quote from Abraham Lincoln. He said, like most of the guidelines, it points the true north from where you're standing, but it has no advice on the swamps and deserts and the chasm which you'll encounter on the way. If we just pursue our definition blindly and plunge ahead, headless of obstacle, and achieve nothing more than sink in a swamp, what is the purpose of knowing true north? Most of the guidelines are which points us what we need to achieve, but we got to navigate with our head so we can modify this challenge. I thank you all for a patient hearing. And these are my answers.